So welcome to the 8th COVID webinar. As you know, this is the CRRG COVID Research and Resources Group that we organize it. There is always more discussion and comments and notes on the Engage. Any questions, send us. I would also like to invite you to the next webinar, which will be in 2 weeks, which will have them by the first couple, that is Daniel and Franz Pfeiffer, radiologist and physicist from Munich, Germany. And then the next webinar would actually fall very close to the APS March meeting, which is from March 15 to 19. I would just like to alert you that in place of that, there are several sessions, two in particular, one organized by the topical group on medical physics together with a forum on industrial physics, which will specifically focus on physics of COVID-19. That's also the one that I'm organizing. And there's another one, which is the Bio and Fat Invited Symposium on physicists responding to COVID-19 and beyond, science and trajectories. So those would be our next webinars. With that, I would like to stop and then hand it over to Gyan to introduce our speaker.
Okay, so thank you very much, Arnoldo, for accepting our invitation. It's a great pleasure for me to introduce you. I met Arnoldo a few years ago at a workshop, and I think we have become good friends since then. Professor Frigessi is a professor of statistics at the University of Oslo, where he leads the Center for Biostatistics and Epidemiology. And he also directs an organization called Big Insight, which is a center of excellence, which develops methodologies to mine big data. Practical methodologies, useful. And so Arnoldo is going to talk about a model that he and his colleagues have developed, or several models, I guess, to study the COVID-19 pandemic in Norway. And the interesting thing is that unlike what happened in places like the United States, the Norwegians actually took these models seriously to some extent and used them to determine the government's response to the COVID-19 pandemic. And since Norway, if you look at the data, you will see that Norway had one of the lowest caseloads and deaths per capita in Europe. Of course, you could say it's because there are so few people in Norway, but it's also because they did something about it right off the bat. And so it would be of great interest to learn how these models work and how they were used by the government. So please, Arnoldo, we're looking forward to your seminar.
Thank you very much, Gyan. Thank you very much for inviting me to share with you some of my work and thoughts. You see my screen now, I guess. Yeah. So this is about the models that the Norwegian health system is running every day to help them take important decisions. And I was so lucky to be part of this group. It has been a very interesting experience. And I hope that I can share some of these interesting parts of this story together with you. I'd like to start by acknowledging the Norwegian Institute of Public Health COVID-19 modeling team. It's a wonderful group of young people. We have been working together for the last year really a lot. Meetings early in the morning to see what the runs tell us and the models tell us, and I think each of the people you see here has contributed enormously to what I'm going to present today. I'll start with telling you a little bit about Norway. So Norway is a country up there in the periphery of Europe, right? It's a small country, half of Texas in area, 5.4 million people. The density in the USA is 4 times Norway, and the capital has 700,000 inhabitants. It's a small place. It's a small country that is lucky to have a lot of oil. The GDP is strong. It's $75,000 per capita. It's the fourth in the world, more than the USA one. The GDP decreased by 6% last year, which is a decrease that is not enormous compared to others. And the richness of Norway is put in this oil fund, the governmental pension fund, that has almost 1 trillion in assets and owns 1.5% of all the stocks in the world. This makes this a country that has an economical capacity to also handle difficult situations like this. Unemployment currently 5.2%, usually it's 4%. It went up a little bit, but not very much, as you see. And just to give you an idea, the average salary of a nurse is $70,000. It's, as far as I understand, like in the USA, while the salary of a surgeon is half than the one that an American surgeon would have. The welfare state in Norway is very strong. I want to tell you about this because it's important to understand a little bit about how it is organized to see the context of the COVID-19 work that we've done. So first of all hospitals are owned by the state, and they are funded by the national budget. Approximately 10% of the national budget goes to the health system. And medical treatment is free of charge for everybody except for a small thing. The expenditure on healthcare is among the highest in the world per head per year, and it's funded by tax. It's not funded by the oil revenues. The health system is regionalized, which means that the 356 municipalities are responsible each for their own local COVID work. And some of these municipalities are very small, right, with a couple of thousand or inhabitants. And in this picture, we should also think that not everything is perfect. So Norway has the longest waiting times for elective surgery in Europe, for example. This is the context. And now we jump to the COVID-19 situation. It was the 12th of March 2020, a little less than a year ago, when Norway went into the first lockdown. And it was a quite serious lockdown, not with curfew, but it was a serious lockdown. I'd like to, and this was the press, when this was declared to the press. Here you see in the middle is the Prime Minister and the Minister of Health. And then you see on your right, the Directorate of Health. And then here on the left, Camilla Stoltenberg, the director of the Norwegian Institute of Public Health. Their role is very clear in Norway. The government decides based on the advice that they get from the Norwegian Institute of Public Health, and the Health Directorate implements. It's a very clear distinction of the tasks. We work together with the Norwegian Institute of Public Health. We work at the Norwegian Institute of Public Health and help produce the documents that have really played an important role. If we jump back to those days in March 2020, the 10th of March, Norway had approximately 300 cases. More than half were imported from abroad. These were tourists coming back after a ski week in the Alps, in the Italian or Austrian Alps, and they took with them the virus. But already at that point, 81 were infected in Norway. So it had started to spread. 2 days ago, the numbers had increased. You see in your head the exponential growth, but it was still a lot of importation from abroad, and we had the first death. And at that point, we had been working already for about a month on our models. And in fact, our models were on the table when the decisions were taken about the first lockdown on the 12th of March. The policy of the Norwegian government is to keep control of the spread of the virus. And what does control mean? Well, control means that the number of patients should be manageable for the health system, and that the number of cases should allow an efficient testing, isolation of the positive cases, tracing of all contacts, and put these in quarantine. This is what control means. And the other important aspect of the strategy is that local interventions are allowed and in fact encouraged. The instruments are a little bit the same. There's nothing special, right? It's the usual stuff that we have in all these countries right now, you recognize all these things. There has been no obligation to work from home, but it was only in that period in March it was really enforced, but otherwise it's only encouraged. Schools have been closed and in a couple of occasions, but there is a policy to keep them open as much as possible. There has been some limitation of mobility between areas that were particularly rich in cases, but not very much. And so we had some lockdowns, but they were not completely full lockdowns. There were no curfews, but the intervention has been quite strong and quite early in the phase. I just take a look to the data just to go into it a little bit. Here you see the cumulative deaths per 100,000 of the US and Norway, and you see Norway is not one of the best countries, right? It's in the middle there among many others, but it's below the US, right? And here you see the number of new confirmed cases in the US and Norway. Again, not a dramatic difference. There is a difference, but not a dramatic difference. Here are the number of positive cases per week from the beginning, from March until today. We have around 2,000 cases every week now, roughly, and this represents 2% of all tested. And of course, you know that these percentages are very dangerous to look at because it depends how much you test. And this is a number of tests that have been made in Norway from the beginning. I think yes, maybe from April until now. You should take a look to the blue curve. The blue curve. This is the number of tests, the number of first-time tests. Cases are usually tested first and found as cases, and then they are retested maybe even a couple of times to see when they are free of the virus and can have contacts again. Here you see only the first test, and in green you see all the tests made in total per week. So there is a difference, and the number of tests per week. The number of tests has been in total 3.4 million in Norway, which represents 63% of the population. The corresponding percentage for the US is 23%. If you look to the number of tested for the first time, is 43% of the population. That's a really important number, 43%. It's a high number. I don't know the American number here, but it could well be 10% or something like that. Norway is a small country, and the testing has reached very, very many. Although the number of tests per inhabitant is more or less the same in the US and Norway, as you see. The most important aspect of the Norwegian policy in protecting the population for COVID has been contact tracing. In a recent paper that studied the UK contact tracing policy, that curve that you see here on the left has been published. This is the estimated proportion of contacts who were reached by the tracing. And it's roughly 50%, right? So this means that 50% of the contacts of a case have not been traced and not be put in quarantine in the UK. I don't have this number for Norway, and I tried to find it and I couldn't find it, but I would expect this number to be 80% or maybe even higher. In Norway, the contact tracing is fully operational. It has rarely been saturated in the sense that there has been a couple of days in Oslo where the contact tracing didn't happen as rapidly as it should. And this despite the app that has been promoted twice by the government to be put on every mobile phone, the famous app that could help to find the contacts. has failed. So the number of people who have it in Norway is I think it's below 1 million. So there are no, I mean, there are very few cases that have been traced by the app and not by a handmade in-person contact tracing. I think one more thing. These are the vaccinations. So these are the number of vaccinations per 100,000 residents. You see them here, and it's a big difference between Norway and the US. Norway doesn't receive very many vaccines. When they arrive in Norway, they're used within 1 and 2 days, and then we wait for the next deliverable. So it's a serious situation. I go over now and tell you a little bit how we worked as the modeling group. So first of all, the task we have was quite precisely defined, right? We are supposed to predict the number of COVID patients in, let's say, the next 3 weeks or for the next year. We have to predict the number of patients that require hospitalization because of the COVID-19, and in particular those that require intensive care units or mechanical ventilation. We have to estimate prevalence and reproduction numbers that have been used very actively by the government to take decisions. And all this we would like to have at national level, but also at regional level, because of this wish to have regional policies. The north of Norway is almost free of virus today, but it is still there are national decisions that they have to follow also there. And very recently, we have been working very actively on the vaccination strategy. So Norway has a national vaccination strategy, the question was who should be vaccinated first and second and third and so on. The first and second is easy, but then it becomes difficult. The data that we use are good. So the Norwegian system has a centralized registry. So we have the daily total tested and the total positives, as I said, excluding repeats. We have the total positive tests that have been imported from abroad, which means they have not been generated by the Norwegian system. And we have the new admitted because of the COVID-19 disease to all the hospitals in Norway. And you know, this is not particularly difficult. There are 25 hospitals in Norway, maybe, right? And so you have to imagine a system that is easier to control. But these data are good because they are complete. There are also, of course, other types of data that we have not used. So we have not used ICU data and not deaths because of various reasons. We can come back to this. And all these data are at municipality level. So there are 356 municipalities in Norway. The other important source of data that we have is about mobility. So Telenor is one of the big mobile phone operators in Norway. It covers approximately half of the market. And we receive data every 4 hours from Telenor that tells us the total number of people who have moved, or phones, who have moved between every pair of municipalities. So how many people between 12 and 6 p.m. Moved from Oslo to Bergen, and how many, a full 356 by 356 matrix every 4 hours. And the data are enormous. So in fact, it's a little bit more complicated. During those 6 hours, only the first 2 hours are checked. So we don't observe all movements, but only the ones that happen in the first of those 2 hours. And the last location is recorded. So we only know, we have only snapshots, very regular snapshots of the mobility. And because of privacy, when the counts are below 20, they are censored. But this is very precious data, right? That tells us how people move and how the virus is carried from one municipality to another. It's particularly important in the beginning of an epidemics, When the virus is everywhere, this doesn't count very much anymore. But it's also important every time interventions take the virus down, and we are in some sense again in a start situation. Mobility is very interesting to follow in itself. So here you see, if you look to the red curve down there, this is the number of movements out from Oslo, from the capital of Norway, from daily from March until today. And you see the scale is I think in 1,000. You see it started up around 100, and then it went down immediately during the lockdown, the first lockdown in March. It collapsed, and then it started to slowly go up. People moved up again. It was decently high in June. Then it's vacation in July. People don't move. They sit on the sea in the sea hytte and watch the water or go in the water. It's very cold, but people are swimming here. And then it went up again. And here you see the level. Here is another lockdown. We had a lockdown last week of October, and in the beginning, and you see the lockdown was very early, right? I'll show you the data in a minute. But very interesting, the lockdown was stopped in the beginning of December, and there was a very strong peak of movement in the first week of December, first 10 days of December. This peak of movement is responsible for the second wave of Norway, probably, together with maybe importation. And then it went down. We are in another lockdown, and we are down again to a very low level. In the summer, everybody who couldn't take their vacation in Italy and Spain because the borders were closed, they were discovering the north of Norway, and look here how many people were up there. So yes, I told you about the shopping, that terrible week in the beginning of December. It's shopping, and it's businesses that fill up before the end of the year, and then the drop at Christmas. Good. Our model is a regional metapopulation model, and it's based on three components. One is we use the sensor data of Norway that are updated in January 2020, which gives the population structure at municipality level with age structure and quite a lot of details. This is where we place the people in our model. That's where they are placed. We have then a compartmental SEIR model that I'll describe for you in a minute, that describes the spread, and the movement between municipalities of individual follows the mobility data that we get from Telenor. This is our SEIR model, and I'm sure that you have seen many models that are similar like this. It's not very special, right? You are susceptible, and if you're unlucky, you are exposed, you are infected by, you have the virus in your body. You are non-infectious and you don't have symptoms for a few days until you have an enough strong viral load to be either going in this direction, where you end up to be a symptomatic case, where you have strong symptoms, or you remain an asymptomatic carrier. These are the ones that are very special for the COVID, as you know, because they are difficult to detect. And then you're recovered or death or so on. There's also this important phase here that I'm sure you have heard. This is a couple of days where people are highly infectious but don't have symptoms. These are the dangerous days where people are behaving normally in the society but carry the virus and are very infectious. This is about 2 days. Now, a key parameter in these models is always called beta here. It's the level of transmission, right? It's the parameter that controls the transmission of the virus, and we have one for every day T and for every region F, and these regions, they're called fylke in Norway. They are 11, and they're shown here in this picture. Oslo is this dot here. Here, this is the far north. So these are the parameters that we will need to estimate to understand the reproduction numbers. the usual differential equations that run such a model. It's stochastic differential equations. It's a stochastic SEIR model, and those who know these things would be able to sit there and write it down. There's nothing special here. There's many parameters that need to be fixed in such a model, and we want to fix some parameters and estimate from data others. What is important for us is that we learn or estimate some of the parameters from the data that I mentioned before. So for example, one parameter that we don't estimate is the percentage of asymptomatics. This is set to 40% based on studies. I think they go back to the famous cruise boat in the beginning in Asia. I think it's 40%, right? And the one that are asymptomatic, they are infectious, but they are much less infectious than the others. About only 10% of their infection. This 10% also comes from other studies. So many numbers are not, or I mentioned here that this the pre-symptomatic compartment lasts for about 2 days, right? I think it's exponential 2 days, and this comes also from studies. So these are parameters that we are not estimating, and we think that we have a decent support for them. The betas are estimated, and that's the important part. Reproduction numbers can be computed from these parameters by computing a certain eigenvalue if you want, but you have the formula here. It's easy. Once you have estimated the beta, when you have a number for this, all the other ones are known. So you can get an estimate of your reproduction number. And the effective reproduction number, that's the one that is then takes into account how many susceptibles are left in your system. I have to say something on how the movements are really happening in our model. And there are many ways of moving people. If you know that, let's say 300 individuals moved from Oslo to Bergen during a certain 6-hour period. And then in the next 6-hour period, 200 are moving from Bergen to Oslo. Now, in our model, we have to decide who we're moving back. And we think that commuting is the key aspect of mobility in Norway. So what we do is that we first send back residents in the municipality where we have to send people to. So for example, I'm in Bergen, I have to send 200 people to Oslo. I take people from Oslo and send them back home. That's the first step. If I don't have enough people, then I'll send other people to Oslo, not the residents from Oslo. And if I still need more people, I will send the Oslo people there. And this is the algorithm. We could think differently, and we should test different approaches, but this is somehow taking into account that the residency of an individual is a point of attraction, and that you tend to go back to that. When we do prediction, we don't have the movements of the future. Then we simply use the last week and we repeat it in the future every week identically. An important aspect is that these matrices that we receive from Telenor, they don't conserve the population. So if you denote by XIJT the number of people who were in location I at the end of the time t-1, and then we're in location j in the next tracking periods. So then you have these matrix xijt, and then you will have a matrix xijt plus 1, and so on. And if you follow the movements, then this equation 1 should be satisfied. And this is not the case for our data because because the many movements escape the Telenor tracking. And the reason is that you turn your phone off, or it doesn't connect to an antennas and so on, right? And therefore, the fact that we are not conserving the population is problematic, right? Because you can, in principle, deplete completely small municipalities. It could become empty, right? Now, if you make a 3 weeks prediction, this is not going to happen. Sometimes we need to add some immigration, but that's not so very important. But for longer prediction, this is quite dramatic. So we have to regularize these matrices, and we regularize them by it means that the row sums have to be the column sums. If you think that's the issue, and and therefore. The regularization that we do is simply finding a matrix Z that has row sums equal column sums that is closest to the Telenor matrix X that we get. And this is a quadratic programming problem that is easy to solve. And this is done every time before we do prediction. Now I have to tell you something about the hospitalization. I have another 10, 15 minutes, right, Gyan? I think, yeah. Good. I see that you are.
Yeah, no problem.
Yeah, good. So the hospitalization here, we have to say who is going to hospital in our models and when do they go to hospital. And first of all, it's the symptomatics that go to hospital, only them. And the probability of going to hospital has been studied quite a lot. This is a very important paper, SEIR paper from France, published in July, a correction published in July that has studied very carefully the probability of hospitalization per age group. So here you see the probability, if you are between 50 and 59, it's 3%. If you're a boy, 2.6 if you are a woman, and so on. These data are used by us. We adapt them to the demography of each municipality, because we know there from census the proportion of the various age groups. And also we take care of the fact that in Norway, many elderly live in elderly homes, and they would not be transferred to a hospital. So they would be kept in their homes. So the assumption is, first of all, that the disease follows the demography, right? And these are the numbers that we would get at a national level by adapting the SEIR probability. So if you are above 80, then there is almost 30% of probability that you need hospitalization. If you are between 20 and 29, it's 0.6%. But the reality is different. So here you see the age structure of the positive tests in Norway from the beginning of the pandemics until today. So if you follow, for example, this green curve that goes like this, right? This is the group between 20 and 29, and this is the percentage of positives in the population. So if you're high up here, it means that this group is very represented among the positives. And you see that this group here was very represented among the positives in August, September, October. This has been seen in every country, more or less. And the infection has been carried by this age group very much, right? It went down and now it's maybe on the way up again. And the elderly, I think here you see the 40-60. In the beginning in Norway, I told you they were all skiing. These are the rich Norwegians that were skiing in the Alps, and then they understand that this is not so good for them, and they stay in the middle here. But if you look then regionally, the age variation is very big. So here you see this is one region and this is another one. So you see three regions. So it's clear that we need to use this data to really compute probabilities of hospitalization per age group that makes sense in a situation where we don't have an age structure in our compartment model. So we compute a correction factor for each age group, which is the ratio between the proportion tested of each group divided by the demographic proportion in that county, and that allows us to have hospitalization probability that are well estimated. The time gap is estimated from Norwegian registry data. So we have a quite complete data set of everybody who has been hospitalized in the Norwegian hospitals. Here we use the first 1,500 hospitalizations to estimate carefully how much time it takes, for example, between onset of symptoms to be admitted to hospital. We find that a negative binomial distribution with a mean of 7.61 days works well. So it takes on average between 7 and 8 days from onset to symptoms to go to hospital, if you go to hospital. And then with a small probability, you need even ICU, and with a larger probability, you will stay in the ward, and so on. So these are numbers that are all estimated, and we re-estimate them regularly every second week, and we update because there is a change. So for example, we see very clearly that the time in hospital has reduced in the last months because of better drugs, better treatment, and so on. I also have to tell you how we, in our model, send people to testing. And that we do with by using a probability to detect a case. So we have our cases in our models, and what is the probability that one of these cases is detected by a test? And this is simply modeled by a binomial distribution with a probability pi t, which is the probability of detecting a case, right? And here we are both taking the symptomatic and the asymptomatic together. And then we simply model pi t with a logistic function, and we use only one covariate, which is kt, the number of tests performed on day t, the total number of tests. Because of course the probability to detect something will depend on how is the effort to test, right? And this simple logistic regression has two parameters, pi 0 and pi 1, two coefficients that need to be estimated. And we are estimating them. We don't know them. And there's also another important parameter that we need to estimate, and this is the time gap between the day of transmission to the day of testing, which is also estimated. Now, this model is assuming that the number of positive tests is a surrogate for the effort of finding the positives. And in some sense, it does, right? So if you test very little, well, you will find very little. If you test a lot, you will find a lot. But there's also a question on who you're testing, right? What is the other criteria that guide you? You might remember that in many countries, in the beginning, you needed to have symptoms to be tested, and then this was not needed anymore. So these different aspects are not captured by our model. I want to tell you something about the two models that we have for these transmission parameters. One is a change point model, and one is a daily varying model. I might say something also about the way we do inference. So first of all, on the change point model, well, you know, we know quite exactly when the government decided different interventions. Here, this is the lockdown on the 12th of March, closing of schools, for example. They were reopened on the 20th of April. So we follow very closely the interventions and put change points in a designed way in the right moments. And so currently we have about 13 periods with 13 reproduction numbers, the last one acting from, I think, in fact, it's the 18th of January now. And we move them always a little bit to try to capture, to come as close as possible to today, but also to have enough data to estimate the last reproduction number. This is also done regionally. So every region has different periods. Oslo currently has 8 reproduction numbers, and Nordland in the north only 6. Why do we do this? Because we try to use as little parameters as possible, because these sequential ABC algorithm that we're using to make inference on these parameters, they are very slow and converge very slowly if we have a lot of parameters. I'll jump over seeding. We have to seed the system. We use importation to seed it, and I'll mention that to estimate our parameters in this change point model, which are quite a lot, right? 8 parameters for each of the 11 counties, and 5 or 6 additional one. And then we have all compartments which are latent variable. And we use these two data sources. Is the hospital prevalence, hospital incidence in each of the COVID treating hospitals. So the number of new people hospitalized every day, and the tests. And the first important, and these are the data that we use. So the first point that I'd like to make here is that using two sources of data together is difficult. Of course, you think that this will give you more information, right? Because the hospitalization data, they say something on the transmission and on the reproduction numbers, and the test data, they also say something. But the problem is that these two data sets are not completely coherent. So if you look to the first picture, imagine that you have data on a test here. So this is data on the test. Here it is. Then we move back this delay D, and it means that the infection must have happened around here with a certain distribution. And if the infection happened here, well, about 7-8 days after, you might end up to hospital. So the hospital data at this time point here should represent the same thing that these test data tell us. But on the other hand, if you start from the hospital data corresponding to this, and you move back and you find when the infection should have happened, and then you move to the right D, you see that the positive test data should be here. And these things do not correspond. So the way to solve this would be to have a time-varying delay and to have time-varying detection probabilities. But this is impossible in terms of inference, and therefore we have to live with the fact that when we put the two data sets together, we will be better in estimating the reproduction numbers, but we will do worse in predicting hospitalization compared to using only the hospital data. That would be better to do the prediction of the hospitalization. And I think I have to jump a bit over the methods that we're using to do inference. I can come back to this. Here you see how they converge. This is the reproduction number from 0 to 1.5. I think this is Oslo probably. And we start without knowing anything. And these are iterative algorithms that nicely take us to a posterior distribution that we can trust. Some regions, we have very little data and we don't get anything. And this is not because the algorithm doesn't work, or it's simply because there is not enough information in the data. There are very few hospitalizations in the north. There are very few cases, and that's simply very difficult. We get estimates for the reproduction numbers. Here you see the fit. So this is, in the blue, you see our model with uncertainty, and the red dots are the data, and you see we fit quite well. These are the hospitalization, the new admission to hospital. These are the last four. We do a reporting of the delay, so we move them up. That's why we have a prediction here. But some of the these are reproduction numbers. Some of the counties have really very broad uncertainties, completely useless from a practical point of view. Some are completely fine. We do predictions. We have an estimate of the total number of infected people in Norway. This is this blue band here with uncertainty. So these are the number of cases that are walking around in Norway every week. And our estimate is in blue, and the red one is the test data. And we can also study the probability of detection of a case, which is also very interesting. It's about 60%. So we currently think that we detect roughly every 50%, 60% of all cases. And Norway has approximately 2% of cases so far, which corresponds to the very small seroprevalence studies that have been done in Norway. We do prediction for 3 weeks. I go a bit fast. This is interesting. I want to show you what happens when we instead assume that a reproduction number has a daily variation. So now beta T, T is the day. And we abandon the change point things, and we go into a sequential, a state space model and a sequential Monte Carlo approach. And this allows us to estimate, to make predictions of this type. So here you see the reproduction number for every day at t, and with the confidence intervals. And it is interesting to from the beginning until today, until a couple of weeks ago. And it is interesting to see and to understand what has happened. For example, here you see it was the reproduction number, the natural one is around 3 in Norway. I think it matches approximately what it was in the US before any intervention. And after the distancing started and the first lockdown, it dropped down dramatically to below 1. And then it was around 1. During the summer, it went up again with importation from the rest of Europe. And here you see another lockdown in the end of November, it collapsed and so on. So these are very useful figures that also indicate somehow the trend that we currently have. The drop with the lockdown is about 80%, and this has been found also in Germany and in other countries. So typically, a lockdown reduces the reproduction number by 80%, and this is interesting, an interesting number. I think I would like to conclude here by mentioning a couple of of challenges and issues that we have and that people who are doing modeling have. So first of all, when you use more than one data source, for example, testing in hospital, but it could be that others use hospitalization and death rates, for example, these sources of data, they disagree. And it is very important to think very carefully, when is it useful to use them? And we found very clear that it is useful to use them when we do estimate the reproduction number. While if we want to make prediction of hospitalization, then it's probably better to use only hospitalization data so that they don't need to make agreements with the test data, and the predictions in fact become better. A very important issue here is that these are very heavy models. We are currently running the regional model with 2,000 cores, and we have a very, very tough schedule. This is very unusual for us scientists, right? My students usually run their things for a couple of days or a week, or I don't worry too much. But here we get the data on Monday morning, and on Tuesday evening, the results have to be available because they're published on Wednesday morning. So there is a very, very clear requirement to fast convergence, which means that we have to work on the algorithm. And we are currently working on splitting the data so that somehow we freeze the first part of the data but keep track of the uncertainty in some way. Uncertainty propagation is an important issue. Even if some of the reproduction numbers we produce are very uncertain, they're useful in any case in reality. And there is an issue. I told you there are many parameters are fixed from the literature, and this is and of course they're also estimated, right? So therefore we have a serious problem in underestimating uncertainty. Vaccination, which is starting to happen now, as I told you in Norway, we need to have it into our models because, in particularly because the elderly are vaccinated now in Norway. And this means that all these probabilities of hospitalization need to be rethought. It's difficult to do it in a model like ours where we don't have age structure. And the reason why we don't have age structure is that we don't have mobility for the ages, and we would have too many parameters to estimate. So we are working currently to thinking, how do we do this properly? It's easy to vaccinate by simply moving somebody from the susceptible to the recovered, right? But the point is, how do you send to hospital the ones that remain? And then there is this issue of the variants, the viral variants. We all have the South African, the British variant, the Brazilian variants, and these variants, they all in principle carry their own reproduction numbers. We are currently discussing, and it will be interesting to hear your opinions about this. In some sense, it will be interesting to know the reproduction numbers, to estimate separate reproduction numbers for every variant. We hear that the British one is about 50% higher than the others, right? This is interesting and useful in combination to vaccination, because if it is true that some viral variants are escaping the current vaccinations, for example, it might be that South African variant is escaping the Pfizer and the Moderna currently, right? So it's possibly important to know to make predictions of when these variants will become predominant in a country. But otherwise, of course, a global reproduction number that mixes all the variants is also good, right? Because it will go up if the predominant variant has a higher reproduction number. So we are working with models where we have compartments for the two variants, and we hope to get some data to estimate them. But it might be not necessary in potentially. I think I'll stop here. There are many useful and good models. I saw that today. There's a paper that came out where 29 models are compared that do prediction of deaths in the US, and they're compared in terms of their power of their quality of prediction and many are useful, and short time predictions are always very good, and long times are more difficult, and so on. Inference is difficult with these models because there's not much data. The epidemiological systems are complicated, and there's lots of parameters and lots of choices here, and the models are usually only available by simulation. You don't have the mathematics to solve equations differently, and because they are available by simulation, they are time demanding, and time is an important issue when you want to have results on very recent data as rapidly as possible. Mobility is important. Our Telenor data are useful, in particularly at the early epidemics and at every restart after interventions have reduced the viral diffusion again. A regional scale is very important, and uncertainty is there. And I would like to say that uncertainty is very informative, even if it doesn't tell you very much. It's informative because it gives, it allows you to have trends, and it gives you the possibility to use other type of political or ethical arguments to take your decisions. Thank you, Gyan. I'll stop here.
Very nice. Thank you very much, Arnoldo. So shall we have a few questions now? There was a question in the Q&A that said that there are no privacy issues in Norway, and you were able to get the movement data from. But so I can add to the question. And do you know who these people are, and can you backtrack them if they get infected, or you cannot?
No. So first of all, this data are very are highly aggregated, right? You get to know that a certain number of mobile phones moved from one municipality to another during those 6 hours, right? And it is important to, and you don't track people individually. So when we know that 300 moved from here to here, and then we later know that 200 moved from here to here, but we don't know if it is the same people or others, right? So that's very, very, very safe. We have this censoring at 20. So there are some municipalities that are very small in Norway, and there are places where there are two people moving from A to B every day, and everybody knows who these two people are. So this is censored if it is below 20. It's very different from the GPS information that you could collect on phones. That is an interesting discussion that we could take. I don't know what apps today are running around in the US. I would be interested to know. In Norway, we had the first version where there was an app that had both GPS and that had GPS locations. So the data were all centralized, and that was stopped by the data privacy agency, and it has been stopped. And the current one that is available today, which is using the Apple Google technologies, is underused, and that's very sad, of course, but it's not used.
I have a bunch of questions, but before that, I guess, Robert, would you like to ask something? There were
no, I think there are a number of questions from the participants, if you see.
Okay, yes. So one of the questions is it possible to use seroprevalence studies to adjust the asymptomatic cases instead of using fixed data from other studies?
That's an very interesting point. So good seroprevalence studies are difficult. There are because you have to randomize and it's not easy to randomize in practice. But there are a couple of studies in Norway, for example, that indicate. I think the confidence interval is between 1 and 2.5 and they only look to antibodies, right, and not the famous T cells stuff. So we use it to validate our results. We don't use this data actively. We use it to check that the prevalence of infected in Norway that we estimate from our model is roughly 2%, and that's the case. But you know, we know so little about the asymptomatics. It's and that's so important, right? Yeah. But it is very difficult to imagine how to do a proper study. We know very little on we know very little of how infectious they are. Mm-hmm. And it's probably a continuum, right? So it's also difficult to. But you know, there are 200,000 papers on COVID produced in the world in this year, yes. And the big questions are completely open and untouched. So I wonder what these 200,000 people are written about.
It's not clear.
And I wonder if this has been a good investment. But I mean, there are important questions, right? That are, and the asymptomatic, and to understand asymptomatics is really fundamental.
So maybe just to add to this, would you say that this is the largest uncertainty that comes in the models, or if not, what would be what do you think is the largest uncertainty that drives overall uncertainty? And obviously they're not like linearly additive. So what's your feeling?
It's a large uncertainty, but probably, now I'm guessing a bit, right? Probably the asymptomatics don't participate enormously to the transmission, right? So yes, it would be very nice to know those probabilities better, but will they change the picture completely? I don't think so. So where do the biggest uncertainty come from? I think it's a heterogeneity of individuals and patients. So for example, we need to understand how much time it takes from a symptoms onset to admission to hospital when a person is admitted to hospital, conditional on that, right? And we get a distribution there, but probably it's much more complex, right? And we would need very much more interesting biomarkers to follow that properly. So I think that the heterogeneity that we ignore is a big part of the uncertainty that we miss.
I had a question, but before that, let me look at the Q&A.
Yeah, there is one similar one is, and I think just on this, do us asymptomatic, pre-symptomatic, and symptomatic cases have the same transmission rate in the model at present? So it's a very specific question to your model.
Say it again, sorry, excuse me, Robert.
Yeah. So do they have the same transmission rate, the different asymptomatic, pre-symptomatic, and symptomatic cases, do they have the same transmission rate?
So pre-symptomatic has, if you take the symptomatics to be, let's say, scale to 1, this is for the symptomatics. The asymptomatics is 0.1, and the pre-symptomatics, I think we are currently using 1.6, but I would need to check. So we have 3 different, we have 2 different factors, and we estimate the beta, right? But these 2 factors are fixed. Hmm. It's a big assumption, that one also, and I think it's more or less the same in all the models that I've seen, but of course there are many more.
Do you see a temperature effect from south to north in the infection?
We didn't look to this, right? But we didn't look carefully to this. I understand that there is a clearly seasonal effect. I don't think it's really understood if this has to do with something connected to the virus or something connected to the behavior of people that is different in the various seasons. I think this is completely unclear, which is also one of these surprising. I mean, the same question is there for the usual seasonal flu, right?
Yeah.
And have they answered these questions for the flu? I'm not sure, well, right?
No, not really.
Not really. Okay.
No, yeah. Not really.
But on the other hand, there are strange. The seasons are not so. They're important, but it's also easy to make mistakes, right? Because we see counter examples where the winter is completely safe and the summer is horrible.
So one of the things is your model is not adaptive, right? So it doesn't actually learn as time goes on from what happened before.
You can say so. So you could imagine that we rerun it every day from scratch. So in that sense, it's not adaptive, because when data accumulate, we give more information. So every time we get new results, right? So we don't need to be adaptive because we can rerun it all the time. But we could be more clever, right? And we could say, well, we have run it until a week ago, and now I have 7 additional data points. Why should I redo everything, right? And I've learned a lot, so let's do it. Now this is what I call the split. We are trying to do it, but it's not so easy to propagate uncertainty properly.
Yeah. So there was a question.
But I would really like to work more on this, because you know, this thing of splitting I mean, we are not so interested anymore in the reproduction number in April, right? No. So we could stop to re-estimate it every day. But on the other hand, the uncertainty on that reproduction number is influencing a bit what happens tomorrow. So we have to keep track of it properly if we want to have an uncertainty for our predictions.
Yeah. So because you could use hierarchical machine learning methods, you know, time-dependent machine learning methods. So you could train a neural net as a function of time, and then make a prediction and then improve.
Yeah. So if you think the prediction is a bit different. So when we do predictions, short-time predictions, we have our estimates now. So we have an estimate of how many people are infected in every municipality in Norway, right? We have an estimate of their production numbers, and now we simply run the simulation forward for 3 weeks. We don't change the reproduction numbers. So we use the constant beta that we have today for the next 4 weeks.
Yeah.
If we would see a trend if we would see that the reproduction number is really moving, we could use the trend further, right? I'm a bit skeptical to these things because all these because it's difficult to see trends in reproduction numbers. It's difficult to see statistical patterns that repeat, because that's what you need if you want to do a trend analysis, right? And they don't repeat because the intervention has been so different and specific, and because of the different behavior of people. So it is such an unstable system, completely out of equilibrium, that it's very difficult to make predictions statistically. So it's easier to make assumptions, right? And look to scenarios and compare and think about scenarios.
Can you include comorbidities in your data? There must be older people have more comorbidity, more likely to go to hospital. So you vary the probability to go to hospital.
I guess that we haven't done it, but I guess that we could have this data because we know roughly in every municipality how many people are in the various risk groups in some sense. We haven't used it. I would need to think a bit, but it's absolutely interesting. Yeah, because you could say,
What about DNA sequencing? Are all Norwegians the genome is sequenced?
The virus sequencing the viruses, right? So Norway is sequencing the virus to see the variants. It's not many sequencing every week. I think it was about 100 until the British variant showed up. I think Denmark is 3,000 every week. So the capacity is not very high, but it went up, and here, Gyan, so as a scientist, I really would like to know who has the various variants. I would really like to know, tell me who has the British variant, right? Because if I would know, for example, if I would have a good sample of the positive cases, let's say 20% of the Norwegian positive cases every day would be sequenced or checked, then I would be able to estimate a reproduction number for the British variant.
Yes.
And then the question is this useful or not? So let's try to think how this could be used. It could be used in one way is that a bit what you were saying about the trends, right? So if I would know that the British variant is going to be predominant in Norway in the next 3-4 weeks because there is a trend, that's the one that you were mentioning before, right? Then I would be able to say that the reproduction numbers in Norway will grow in the next weeks, and therefore maybe the famous contact tracing in some places has to be reinforced to remain able to cope with the numbers that will appear. Another reason to know it is the vaccination strategy, right? I don't know if you have this discussion, yes, right? But the South African variant seems to be tough for the current vaccines, right? And therefore it will be important to know when is the South African variant importantly present in Norway, because at that point you probably have to think that the vaccines you have are protecting less.
Yeah, but the flu vaccine does not protect as much as we believe it does, actually.
That's true.
Everybody
60%.
makes a noise about, it's only 60%.
60%, yeah.
So 60% seems to be reasonably okay for the flu.
Yeah, I agree. The South African, I saw something where it said 10%. That's less. That's a little, right?
That's a bit smart, yeah.
Yeah, but I agree completely with you that we will have to live with this thing,
the other question is, if something is more infective, is it more virulent? Because typically viruses reduce their virulence if they become more effective.
Yeah, I also understand that's how they live, but it doesn't look to be. I mean, the UK variant is maybe the same or possibly slightly more virulent, so I was a bit surprised about that, because also, I mean, from an evolutionary point of view, that's not a good idea.
Not a good thing.
No.
So can I ask?
But let me add one more thing, Robert. Sorry, because I think this is interesting. Another interesting thing, you know, these vaccines, these mRNA vaccines. I was asking an expert. So how fast can they be re-engineered to a new variant? And I asked, and the answer was maybe it's 2 months. Maybe they can re-engineer in 2 months. And if it goes so fast, then it's fine. Then we statistician, we need to do the predictions of the variants, and we need to identify rapidly if a variant is important, because it is possible to re-engineer these things to protect against them. It goes fast, while the other type of vaccines, the flu vaccine, for example, it takes maybe 6 months to adapt.
Yeah. In the meantime, we got a good comment that Moderna is planning to release a booster for South African variant in the fall.
Good. Excellent. Yeah. So wonderful. But in the fall, you know, the fall.
In the fall. In the summer will be summer. No, but I have a question for you. That's kind of like you know, a lot of these models are useful for what if scenarios, and I wonder how much of that has been played. You know, you clearly said, like in early December, the things got open. In, you know, that the mobility increased, the transmission increased, and probably was very predictable that this will lead into obviously spikes, and, you know, probably in the lockdown that you're now in.
Yeah.
So how much of this are you doing of this what if scenarios? Because again, even if you don't have, something is to be as accurate, something is to say, okay, let's assume that, you know, South African will have certain prevalence, will be, you know, whatever percentage has this certain reproducibility factor.
Yeah.
And then just, you know, create a kind of like scenarios that, you know, the government could then prepare actions into that. It's like, okay, we can afford this, but then we'd expect this, or if this is this. So how does this play?
Yeah. So my colleague Gunnar, he's doing that things, and we are doing a lot of those things. So we have been asked repeatedly, so what will be the surge in hospitals if things continue like this? When is the peak? How many people will need ventilation? Our models have been used to buy drugs and to buy protective equipment for the hospitals. So these things are all scenario based, essentially, where we take sometimes a worst case point of view, because that's what they want. And sometimes it's a series of scenarios that we present. The biggest last thing that my colleagues did at the National Institute of Public Health is to make scenarios on vaccinations. So if the vaccines have certain characteristics, if the underlying reproduction number is this and this, if they arrive in batches of this and this type, who should you vaccinate? And then you have to say what you want to optimize. And Norway wants to minimize the number of deaths and the number of hospitalizations. And then I think he told me he did 9,000 different scenarios. And that's what the Prime Minister got on her desk. I imagine that it was busy for her. No, but it's a complex. I mean, only to plan and to run such a scenario study is difficult, right? And to summarize things. And I think that I mean, the summary is that you follow the risks essentially, if the underlying reproduction numbers are of a certain type. If the reproduction numbers are different, then it's worth to instead vaccinate the groups that spread the virus, right? Mm-hmm. It's a big discussion now if Oslo should be vaccinated before the others. And then it's so interesting politically, right? Because yes, it might make sense, but then there will be some additional people who will die in other places, right? Because we don't have enough vaccine. Because the US has bought it, right? Before us. Maybe, I don't know.
Yeah, so now it's getting into interesting discussion.
No, I don't know.
The models are something, but the politics, and there's many other players that have to. Then
yes, and I'm very happy that the decisions are taken at the political level and not the scientific level, because we are not good in putting together the different.
This was also probably a decision that was driven by December opening, because they knew that probably they had to open for the Christmas and holidays in spite of anticipated, or like summer openings, and this is part. So I think we should probably at some point close, even though it's very interesting discussion. This sounds like we should. I guess for you it's probably like the evening, so nice like fireplace. So there is still another question on the error bars, and it was specific as does the sparsity of the data that drives this, but I would expand this. So like in terms of, and let's say maybe now the lessons learned through this COVID times that you have, if you were to redo the models, or if you had or not just the models, it's also data acquisition, etc. What should be done differently? Because obviously, you're dependent on whatever data you can get. That's maybe not optimal. The certain data that would very much, help you, but again, could be taken. But of course, there is no mechanisms or not prioritized. So what do you think could be done that this models could become in the next or in the future more better predictive? What else should be done that goes beyond, current ways? So lessons learned, so to speak.
Yeah, it's a good point. All the data that we receive are imperfect, and in other countries they are much more imperfect than the Norwegian ones, right? They are incomplete. They are there's delays. There are missingness. Suddenly somebody understands that, everybody that doesn't have a personal number is not in that list, and therefore, we have lost 2,000 people that went to hospital, right? So these things happen regularly, not just once or twice, in a country that tries to have a complete overview, right? I mean, I don't know if in the US you have a number that says how many first tests have been done, right? It's possible you have it, but I'm not sure. Because so it's clear that an effort to get better data and to make the flow of data into databases that can be studied is essential. I also think that we need that having modeling groups is not a luxury. Having strong modeling groups that are ready to run these complex models in terms of rapidly when there is an epidemics is so important. So I think that we understand that having modeling capacity in a country is not something that is a luxury that it's as needed as the fire brigade.
Yeah, and do you think that the models will also change and be not just the modeling groups, but also there was also a question about role of AI, for example, because I think we had a nice way of more deterministic models.
I'm a modeler. Yeah, I'm a modeler. I think that mechanistic understanding of models is important, and it has many advantages. But yes, I'm sure that we could do predictions in some way very well with random forests or deep learners and neural nets, and many people do it, right? So I think that it's a very good combination. The reason why I think these mechanistic models will not disappear is that they are very good. And in reality, they are the very first order approximation of reality. But you know, the first order approximation of reality sometimes is enough to answer the right questions, right? And we want to answer the questions that are useful, not first of all. So I believe in them.
Yeah.
So, and I know you do the same. So
I agree. Yeah. For short-term predictions, you want first order. You don't.
Yes.
Yeah.
Yes. No, and you know, and also, as I said, like it's understanding. You know, it's much easier to vary parameters to understand what would be correlations.
Exactly.
Uncertainty that comes as well.
Exactly.
No, this has been very fascinating. I don't know, Gyan, if you got any.
I have many questions, but I'll ask you.
We take them over a coffee the next time you come to Oslo again.
That's what I was thinking, that we should just have a round table or not a round table, a round fireplace and have discussions. So maybe that's what we should do in place of this webinar at some point. So
thank you very much for a wonderful discussion.
Yeah, thank you so much for a wonderful presentation. I think this has been really fascinating. It's great to learn, lessons learned, but also just the intricacies of the work and important work that you're doing. So thank you so much.
Thank you.
I'd like to invite everyone again, like in 2 weeks.
Yeah.
And then we'll be in touch. Thank you again.
See you.
Bye-bye. Thank you. See you.
Bye, Arnoldo. Thank you. Bye.
Thank you very much.